Tim. So.
Thank you so much, Dr. Viswanath. Thank you and welcome. I am Tim Collins. I am a senior epidemiologist at the Alaska Native Tribal Health Consortium in Anchorage, Alaska. And I will be facilitating this discussion on interventions at the informational level and at the individual levels. And this panel is going to explore strategies and interventions at the informational and individual level to prepare for and respond to epidemics. And information at the individual level, they focus on building individual resiliency through strengthening information literacy and pre-bunking or inoculation. Interventions at the informational level focus on amplifying information that is factual, on filling in the information voids, on debunking or refuting false information, information tracking, and establishing information credibility, and verifying information and detecting false information. And from yesterday's panelists, we heard some themes emerge that in operationalizing all of these approaches at every level, it's always important to engage people with respect, humility, and we would have the word compassion used, which means acknowledging the needs and concerns of those communities. And along those lines, we just heard from Amanda, Juliet, Jill, and Dorothy, the importance of practical considerations of understanding the local perspective and responding with appropriate language, with appropriate media, and even spokespersons or people that communicate that who might be trusted in the community. So building on those things, today we have a panel of discussants who combine some pretty vast technical knowledge with some impressive practical real-world experience. Each discussant will have about 5 minutes to give some remarks, which will be followed by a question and answer portion. And if you would like more information about the panelists, a link to their bios is posted on the event webpage. And we welcome questions from the public for our discussants, and you can enter those via the Q&A, which is below, Q&A window, which is below the video player. Please go ahead and enter the questions in there. So first we're going to hear from Rachael Piltch-Loeb at Harvard Chan School of Public Health. He's going to give an overview of some interventions. And then James Smyser of the Public Good Projects, which tracks specifically this information, will talk about contextualizing information for public health purposes and the changing landscapes and implications of the changing information landscape for public health. Jessica Castner from Castner Incorporated and the Journal of Emergency Nursing will talk about how healthcare professionals, those at the front lines, can specifically nurses can intervene at the informational and individual levels to mitigate against the harmful effects of epidemics. And then Adam Dunn, joining us from the University of Sydney, will talk about surveillance and impact. So actionable evidence can be produced to prioritize and design targeted interventions. And with that, we would ask panelists to be mindful of the 5-minute time and to, on behalf of our interpreters, to keep that in mind and to speak in a clear tone. Thank you very much. And with that, we will turn it over to Rachael.
Great. Hi, everyone. Rachael Piltch-Loeb. I am a research scientist at the Harvard Chan School of Public Health and a project director with the Emergency Preparedness Research Evaluation and Practice program there. I'm sort of setting the stage here for thinking about individual and informational level interventions. And then I'll focus briefly on the notion of inoculation theory, attitudinal inoculation, or pre-bunking, and a particular study we've done in that area. The notion here is that there is a continuum of when folks are exposed to mis, dis, or confusing information. And inoculation-based strategies, which I'll go into in a little bit more detail, kind of sit at the beginning of that or prior to that exposure. This is a way in which people can be warned, essentially, that they may encounter content that is false or misleading, and to be prepared for it. But this falls along, like I said, a continuum whereby there's other interventions that can be tried at the individual or informational level as well. These can include kind of nudges or priming people to question the accuracy of the content they're about to see right before it's done. Labeling or fact checks when information is actually being encountered, and kind of a redirect to authoritative sources such as a CDC's website or something of that nature. And then post-exposure notifications, or basically a kind of tip that you've been exposed to misinformation after it's happened, and to reconsider kind of that content. To jump in a little bit more specifically to inoculation and pre-bunking, psychological inoculation is a communication technique. The goal is to build mental antibodies in the same way that we physically build antibodies when we receive a vaccine. Like medical inoculations, the goal is to basically build psychological resistance against kind of a future persuasion attack. And because this language became slightly more controversial during the COVID-19 pandemic, I think in some ways that's why the pre-bunking language came about. We became a little bit less comfortable with the notion of inoculations for the body. And so the psychological inoculation concept, I think, also became a little bit more difficult to talk about. So this strategy can also be referred to as pre-bunking. The way in which these messages actually work is that there's three parts. The first is a warning, an alert that there are kind of an impending mis or disinformation attacks that may try and manipulate you. Then kind of a refutation, sort of the counter arguments to equip you to refute those manipulative messages. And then a microdose, or an example, a small example of a piece of misinformation that you may sort of encounter. And this three-part formula can be used in text-based interventions. It can be used in video-based interventions. It can be used in gamified interventions, which are all different approaches that researchers have taken along a variety of different issues, including COVID-19 vaccine hesitancy. Our team was involved in a study in partnership with American University's Peril Research Group and Jigsaw Google to test 3 different inoculation-based messages in a randomized controlled trial against a video where folks watched a how to make a paper airplane as the control. Also very informative for anybody interested. And what we found was folks who watched an inoculation-based message to promote vaccine uptake or counter the narrative that vaccines cause injuries. Among those who watched an intervention, they were had a greater ability to identify misinformation. They were less likely to share that misinformation, and they were more likely to get or be willing to get the COVID-19 vaccine. So inoculation-based messaging holds some potential as we think about kind of our interventions to address the mis-disinformation landscape. But it is just one of a suite of interventions that are out there as we think through kind of what strategies we can use at the individual and informational level. I'm probably close to my time, so I'll go ahead and pause there and turn it over to the next panelist.
Thank you, Jessica.
Yes, thank you so much. My name is Jessica Castner. I'm professor and director of nursing at the University of Albany and the president and principal of Castner Incorporated. I'll ask Matthew and the staff, Maggie, to upload the slides, please. I want to thank the CDC, Tim Collins, and the planning committee for putting this together. Spoiler alert, this slide has the 3 main takeaways that we'll circle back to. Slide 2, please. I'm joining you from Eastern Michigan today, as it enables a time for a spiritual pilgrimage in the process of completing a circle, where I visit the burial grounds of at least 7 generations of ancestors. This process brings back a key reminder of medical mistrust and exploitation, which resulted in the 1854 Bone Bill in New York State. In acknowledging historical influences, this is a direct result of grave robbery and desecration by medical students in order to supply cadavers for their study. It is a reminder of these historical influences and how far we are from entitled to people's trust when we give medical information. Slide 3, please. Nurses are 4 million strong in the United States of America. Go ahead and advance the slide. With deep relevance and reach across the nation as 1 in every 100 United States citizens. We are more likely than other clinicians to have practices in rural, healthcare provider shortage, and low-income regions of the country, thus demonstrating incredible reach and relevance in addressing health disparities. We serve a unique bridge in applying biomedical and social sciences in holistic practice, which means within the context of people's lives. In this map, the darker green, the higher the priority or shortage area. Yet in the nursing discipline, we have our own shortage, a need that equals about 10% of the currently working nursing workforce by 2025, between 250,000 million registered nurses. When I wake up in the morning, I know as a nurse, I am among the most trusted and ethical disciplines, and that shows on the right here in this Gallup poll. But I'm not entitled to that trust. It must be earned every day and in every encounter. So we strive to be trustworthy as clinicians and as public health workers. This earned trustworthiness may differ by political party. Consider the reach and relevance across the aisle where nurses have among health professions with that greater representativeness in rural and low-income populations, and you see there's less of a divide in that sense of trust across the political aisle. Slide 4, please. Using the Mind Sponge framework, we see information enters our environment as individuals at the center of the target from the external environment. It's parked or filtered through a buffer zone and evaluated before entering our core mindset, beliefs, and behavior. Let's explore this further. Slide 5, please. Here we see a logical process diagram of the Mind Sponge framework with 5 main steps amenable to intervention. This guides us to 5 key interventions in providing accurate health information. The information must be 1, available in that person's environment, 2, provided in an accessible form to culture, to feelings, to literacy, to language, priorities, and core beliefs. 3, provided with a trusted source in a trustworthy manner. 4, given in a way where the individual perceives the benefits outweigh the costs, or in a way that already deeply aligns with their core values and belief. And 5, it must be repeated and reinforced so it does not wane away as irrelevant. Slide 6, please. This is a figure of the vaccine hesitancy framework that I published in one of my editorials in the Journal of Emergency Nursing. I think we need to respect that vaccine hesitancy came from a wide swath of factors in addition to or despite misinformation. Vaccine hesitancy could be a very logical and well-reasoned decision for that individual in their context, whether it's access, cost, the personal cost to take off time off work and travel. If only we practiced active listening to understand and intervene in all of those factors better. Last slide, please. So here again are those key takeaways that if we look at with the information and the authentic respect in the context of people's lives and core values, we can be meaningful with accurate health information. Active listening is a key intervention as well. We're not just here to provide information, we're here to give it meaning and context and action in people's lives. And finally, that key role of the nursing discipline as role models for health behavior, but also that incredible reach. Thank you so much.
Thank you, Jessica. And that is a great lesson that, especially coming from nursing, that from the perspective of the individual, their decision makes sense, and that's a respectful way to engage them and not to be dismissive. So thank you very much for that. And Joe, I think I got a little bit out of order. Joe, if you want to have your presentation.
Sure. Yeah. Can everybody hear me okay? Okay, great. Well, thank you for having me here today. I appreciate it, and it's been great to listen to all the other speakers. A lot of really good points made. It's impossible to. The reason I didn't show up with a PowerPoint today was, it's 5 minutes, and we're trying to cover a lot in these 2 days. So it would be impossible for me to go into the layers of nuance around infodemiology in 5 minutes. But what I'm going to do is just give you a really quick overview of my background, and then some of what we're seeing, and then I am sure we'll all have an opportunity to go into more in depth as when we get into the Q&A. But my personal background is I'm in public health. I've been in public health my whole career, and I have the distinction of being the first dissertation in public health that used advanced media monitoring systems for health communications. So that was in 2010, which feels like forever ago. But then I went on to postdoc at CDC, and after CDC, I was a contractor for FDA, always in health communications and media monitoring space. And then I've been at my organization now, the Public Good Projects, or PGP, for 7 years. PGP does a lot of media monitoring. So we use really, really advanced media monitoring systems to track, tag, and respond to a whole range of priority public health topics: infectious disease, vaccines, sexual and reproductive health, mental and social health, tobacco control, nutrition and school wellness, et cetera. So I've been in this space for quite a long time. We run some of the largest vaccine misinformation programs in the world, the largest in North America and the largest for the UN. Just some observations that we have. I think WHO did a really good job in 2020 in rising to the moment that the pandemic presented and branding the problem that global health and public health had. It was an infodemic. We now need to move past that. We run a risk now in falling into the same trap that Homeland Security fell into post 9/11 in the United States, where every day was an orange alert, and so the populations we go to work every day to serve started to. You were always the boy that cried wolf. There was never an actual emergency. Every day felt like an emergency, which means nothing is an emergency. But that doesn't mean that the field of infodemiology has no value. I would just caution against taking something that was new to public health, but not new to many other fields, and pretending like holding a grain of sand represents the entire beach. The infodemic that we all are still grappling with, and that will never go away, it was novel to us in health communications and crisis communications for public health and global health, but in many, many other fields, political science, cultural anthropology, public relations, journalism, they have other terms for this problem, and this problem has been around a lot longer. Didn't magically appear in 2020. It was just the first time it affected us. And that there's a lot of information, and there's a lot of standard operating procedures and thought leadership and really good tools and methods that exist in ancillary fields to public health, particularly journalism and public relations. And I say this as someone who is a leader in my own field, but I typically draw, and my staff typically draws from those fields. That's where really the most coherent thinking is, the most long-term thinking, and the thinking with most of the evidence around it. Though there might be scant evidence for what an infodemic means, there are libraries full of evidence for what an infodemic means by any other term in any other field. So I would like to just end by saying, I think we should use this as an opportunity to build public health back better. We have state and local health departments all across the country building infodemic management teams, despite whatever they're calling them. This is going to be part of the bread and butter of what the work of public health is. This will be shoe leather health communications moving forward. So we need to move away from a crisis communications response where every day is a crisis, and more into institutionalizing how the tools and the techniques and the methods and the thinking actually works within the US context. And I think a field of infodemiology makes a lot of sense. And I think that's where we're all going. But when I mean build back better, I mean we have everyone's alluded to this, we have a huge problem with trust. Nobody trusts the CDC anymore. And of course, I'm overgeneralizing, but we have a huge problem. It's now major talking points, and one of only two parties is how public health has consistently failed to show up. So let's use the excitement and the energy in this new field this new field of infodemiology, to galvanize support and cross the aisle and make new friends, make new stakeholders, new partners, new allies, so that when we approach public health in all these new ways that we're all talking about, we have a real shiny new thing that we can use as leverage, that we can use to build back trust. Because the other half of infodemiology isn't just identifying and tracking and responding to an overabundance of information or mis and disinformation. It's also, how do you do that? It's who do you give that information to? How do you empower them in that process? And when is it appropriate for your stakeholders and your partners and allies to speak, and for you in public health to be silent, to be a passive observer, to be behind the scenes, just providing information? That's the landscape that we all exist in today. And for our part, that's where we're spending most of our time, is how can we operationalize this? Let's move past this idea of an infodemic. This is just the future for all of us moving forward. Let's get down to the bread and butter, where the rubber meets the road, in terms of operationalizing it. Thanks a lot.
Indeed, excellent points. For situational awareness, the importance of having media monitoring in place, of being able to understand what is being said and how the environment is changing is as we learned, critical. Adam.
Thanks for having me, and thanks for the invitation to be part of the workshop. So my name's Adam Dunn. I'm a professor of Biomedical Informatics at the University of Sydney in Australia. And I acknowledge that I'm speaking from the traditional land of the Gadigal this morning. I've been doing data-driven research on health and misinformation and its impact on behaviours for about a decade now. Our first work in the area was 2014, where we showed that we can predict a Twitter user's first tweet about HPV vaccines, whether or not it would be critical or anti-vaccine, based only on who they follow rather than what they say. Since then, we've published over 40 articles on misinformation and infodemiology, mostly in the area of vaccine hesitancy, but spanning machine learning, public health, communications, social psychology. So this section of the workshop's on interventions, and I often think about how it's impossible to create interventions that will reach and influence all people about all relevant health issues all the time in all information environments they exist in. In the past session, I was kind of struck by the amount of effort it takes to support minority communities just in the United States. That energy is amazing, but we really need to be able to prioritize where resources are allocated in vulnerable populations who are most at risk of harm, most susceptible to misinformation. And we need guidance on being able to design interventions that can be delivered in the information environments where people already access and trust health information. The critical challenge is that the vast majority of social listening and data-driven research in the area just counts up misinformation on social media platforms and media, and it's fundamentally not designed to robustly measure what information people are actually exposed to, and almost never measures impact on attitudes or behaviors. So they're simply not as actionable as we want them to be, and we can't really use them to guide or prioritize where interventions are needed right now, or to design those interventions either. And as Jessica mentioned, we really need to understand the context of people's lives. Social psychology studies are a bit better at measuring the influence of attitudes because they recruit participants into studies and ask them, but they're also constrained by the need to control what people see and put participants in artificial scenarios. So working with the World Health Organization, we wanted to fill this gap by building tools that can actually find those associations between the information that people see and hear and their attitudes and behaviors at scale and for health issues affected by misinformation, such as vaccination. So we developed the information diary platform's main tool was a kind of a smartphone-based version of an old-fashioned media use diary. And within 6 clicks, people can record any encounter with relevant information about a health problem. This doesn't just include social media platforms or websites they find while searching, but conversations with a doctor, a friend, a stranger, a poster in a clinic, local newspapers, or advertising they see while online, watching TV or on the side of a bus. So importantly, this also asks participants to decide how much they trust the information that they're seeing. They might trust what a doctor tells them and distrust the content of a YouTube video, or it might be the other way around. So we evaluated this platform in a pilot study on statins, which is affected by misinformation, with Dr. Hoimin Lim and her team in Malaysia, and we found that it works well. And the way it's set up makes it cheap to run these kinds of studies. So the analytical approaches we're testing now will be able to tell us things like, people with university education in their 40s who have high levels of trust in health information they see on Facebook are 3.5 times more likely to reject statins than other people after accounting for confounders. You can imagine how this kind of fine-grained information can then be used directly to inform local public health interventions, targeted health promotion to people in their 40s on Facebook, and teach critical appraisal or use inoculations at a graduate level. But the real reason we wanted to build this platform from the start was so that we could patch together data from many of these studies all at once as a kind of giant quilt made of these kinds of studies to look for risk signals that are common across locations, across populations, across countries. We want to make sure that local researchers will be able to use local research to support local public health organizations on local actions, but also join in as a part of a consortium that will publish one of the first large international analyses of risk signals that predict certain attitudes, such as influenza vaccination intentions. So we still have a few things that we need to do to turn this idea into reality. But given that we can't deploy all the interventions everywhere all at once, we really need an approach like this to have proper evidence of where our interventions are going to have the biggest impact. And we need to know where and how to deploy them in the spaces where people already access and trust health information. So I'll stop there and I'm happy to answer any questions.
Thank you so much, Adam. That is indeed, during the pandemic, a lot of organizations were inundated with data, and being able to put that data to use to target information and make sure that people who need it most get it is indeed worth underscoring. Thank you so much to all of our panelists for their remarks. We want to remind the audience that if you have a question you want to ask the panel, just drop it in the Q&A window beneath the video player, and we'll try to get to that as soon as possible. For the panelists, though, we covered some of the changing landscape and the changing technology. We talked about media monitoring, which is an area of rapidly changing technology and capabilities, as well as platforms that need to be monitored. So for the panelists, I'm wondering what additional research or evaluation is needed to fill knowledge gaps in the area of environmental or individual level intervention.
I mean, I can jump in if nobody else wants to. Look, I think all the research is needed. One of the things that we struggled to do well in this space, have struggled to do well in this space in the past, has been interdisciplinarity. And I kind of feel like, sometimes we get, and I'm speaking from, as a computer scientist, sometimes we get a whole bunch of computer scientists jumping in and saying, hey, we've got all this data we can access, let's see what we can do with it. And they come up with conclusions and draw conclusions that are just wrong. Unfortunately, we need the ability to work closely with public health people who work on the ground, with social psychologists who understand cognition and understand how the kinds of studies that need to be done in the space, to work with communications experts, to work with people, with journalists, with media, with everyone all at once. And so I think it's not so much any specific kind of research that needs to be done. It's probably the glue that sticks all of that research together that is going to be where we're going to get the best wins out of this.
Thank you so much, Adam. A question for Rachael. How can this type of strategy be implemented? This is from our audience. How can this type of strategy be implemented into schools at an earlier age?
Yeah, that's a great question, and something that's exciting to think about. I think that the use of some of these tools is a form of digital literacy education. So I think that there needs to be awareness at a much earlier age about what exists in our online and offline, but let's focus on, I guess, online at the moment, information environment. So that could be as part of curricula that's taught in high schools or earlier, thinking through how we engage with the online information environment. I don't think that that's systematically being taught in our education system, but it's something that is going to come up for all generations kind of moving forward. So I think thinking through kind of building an awareness to what exists in the online information environment is really critical for our population.
Thank you. And for the panel, can these interventions be implemented more broadly? What is the evidence base for other situations?
I can offer one thing, but Joe, if you want to go ahead. Okay. Yeah. For, what we've thought about this a little bit in our inoculation work. We've done some work with YouTube to try and do what's called brand lift studies, which is placing inoculation-based videos as YouTube advertisements and seeing if we get a response that folks are better able to identify misinformation-based techniques or less likely to share misinformation-based content after watching those videos. And we saw some effects even in, after 100,000 kind of folks had viewed our videos compared to controls. It's not a perfect public health study design environment, but it's something that at least gives us an exemplar that this could operate in a more realistic environment versus just a lab space where we're able to do a randomized trial.
Along those lines, Jessica, you talked about the role of nurses and providers in communicating with people, but during the pandemic, we saw and we're talking about applying these methods broadly, but during the pandemic, we sometimes saw wrong information coming from people in the medical community and in the public health community. It was mentioned earlier, the promotion of ivermectin by some. What are your thoughts on responding to misinformation? For Jessica and the panel, what are your thoughts on responding to misinformation when it is presented by somebody who appears to be credentialed or representing a trusted institution? Do you have any thoughts on that?
Certainly, I really appreciate that. And, often our best recommendations are based on clinical practice guidelines. They are based on rigorously done systematic reviews, and the velocity and the speed of information in the midst of the pandemic did make that difficult. And we had to ask for people's understanding and negotiating. But I also think it's really crucial in those public mass media outlets that we develop through our professional organizations, really strong relationships with the media, because both sides of the story can mean information and misinformation when it should mean this core value and that core value with best practice information, so that we're basing it on what's peer reviewed, what's expert consensus, and presenting that with a unified voice.
Could I add something to that? I would just say, I think we're in a really unprecedented time, and I think we all feel that. I think public health has pretty good relationships with media, but a lot of us didn't speak up. We were muzzled during the pandemic by our institutions. So some more bravery on our part and a different way of. I had a bunch of reporters tell me during the height of the pandemic, nobody in public health would ever pick up their phone and to answer a question. And I think that was just fear of losing jobs and also mass confusion around what our role was. Some of it's understandable. But, we were Twitter's primary partner in helping them tackle vaccine misinformation during the pandemic up until November, when that team was largely dismantled. And we still work pretty closely with all the social media companies. What we hear all the time is that public health doesn't speak with a unified voice. So we have no policies or regulations in the United States that allow a single point of contact for tech platforms or communication platforms to speak to public health. We have every single organization that believes it represents public health all trying to get in touch with the same 5 people at all the different social media companies. So it becomes a game of whack-a-mole for them, and a game of who has the greatest influence and strongest social network for public health. which is a huge problem. And we also have the institutionalization of misinformation in this country. The US exports more vaccine misinformation than any other country on the planet. We have all the data to support that claim. Most English language, I should say. And we have state surgeon generals, we have elected officials now spreading what I would call disinformation every single day. 2 years ago, we were kicked out of a state because we were trying to give Native American First Nation communities access to information about where to go get vaccinated. And we were using best practice in the social science research, linking motivation to get vaccinated with cultural values. And that was viewed by a certain governor's office as working against their party. And so we were impolitely asked to shut down the program and leave the state. That was 2 years ago. It's vastly worse. And I will just say, for those of you who aren't in this space every day, there's more misinformation than there was 2 years ago. The problem has not gotten better. It's gotten exponentially worse. And in terms of share of voice of who is creating the misinformation, healthcare workers are a much larger proportion of the share of voice than they used to be. Physicians, nurses, chiropractors were always a problem prior to the pandemic. But now we have a whole host of other people who have the right credentials after their name and wear a stethoscope and a white coat, using the opportunity that this chaos presents them to build up their own brand. So it's less, I think, about public health moves slowly and methodically. These are people who are weaponizing the legitimacy that the institutions that they went through give them. And we haven't quite figured out as a society what we do with that information yet. There's always the problem of science moves slowly. How do you communicate that? That's not a new problem, though. Climate change has been facing that since the beginning. We really need to figure out, okay, if you're in public health in the United States, what's your role now? It's the facts and the science no longer speak for themselves, which means we need a whole group of stakeholders and partners and proxies that speak on our behalf, on behalf of science, because we can't do it alone anymore. Thanks.
Thank you, Joe, for those thoughts. Anyone else on that question? You've done everything you can. You've followed all the approaches, but you're looking at your map or your spreadsheet, and you can see there's still this region or demographic where nothing's moving, and people have their preferred information channels. They are entrenched in their ideas and have been not really open to other information. Any other thoughts on approaches in that context?
I'm happy to take that on. I think that as we look at information giving, it's education and training, even in a mass media combination, but health behavior and the decision to accept that information, to integrate it with core behaviors, is also part of your capability and your motivation. And that often takes a more on-the-ground approach, grassroots up through those faith communities, through those volunteer organizations or where people are. But if information was enough, we wouldn't have people who still smoke cigarettes in this country. We also have to have capability, we have to have motivation, and we have to start to address those holistic factors in context.
Along those lines, I appreciated the comments yesterday from Dr. Zink, not to give up on people, to keep engaging, and to, if they don't respond to anything else, you can at least show compassion and understanding and make a connection with those audiences. So thank you so much, Jessica. Question from the audience says, I appreciate Joe Smyser's reminder that public health is not the first field to tackle infodemics, and that other areas have done this work and done it well. Can he share terminology that other fields use in place of infodemic or infodemiology? Are there any other terms that you would use?
No, not really. I think that's actually one leg up that we have over the other industries, as we created a catchier term for it. But no, I mean, I think, look at journalism. I've actually found, because half our organization just does media monitoring all day, every day, 7 days a week. The other half works on tailored health communications out. through lots of ways. So we've had to build teams to do this work. And I have found, and again, I say this as someone who's only worked in public health my whole life, journalists are far superior than public health grads in doing this work. Able to process a vast amount of information very quickly, immediately understand the through line, are trained to communicate to different audiences from day one of their training, and often are used to working very, very quickly and using a weight of evidence approach. Public health grads from MPH and PhD programs who supposedly graduate as experts in health communication know almost nothing about that, but they know a lot about theory. So I think we have a lot, rather than trying to figure out the where to look for other information, it's very easy to find it. I'm happy to share some links later from other fields. It's not in PubMed, so if that's where you're going for your information, you're not going to find a lot except for more Twitter studies. But there is a need for us to grab what we can and for more cross collaboration, more cross-sector collaboration. And there are a whole bunch of journalists who believe just as strongly that their mission every day when they go to work is to advance society and to help people, empower people, give people the information they need for good decision making, just as strongly as those of us in health communications do. And they are the fourth estate. And there are a lot of them that don't have jobs. And we have a 40% workforce shortage in public health. So maybe we should start hiring up the people that just got laid off from all the big journalism places.
Thank you, Joe. When we see that some demographics, though, the journalists are among the least trusted, how might you respond? You have all this data, you know exactly what you're looking at, but say the people that you want to reach have a very low trust in journalists for whatever reason. How might you adapt your response in that case?
Well, real quick, because I know other people have probably some really good ideas here. I would just say I don't actually believe that. I think people polled for their trust in journalists think of a talking head pundit, and nobody respects or trusts talking head pundits. It's a circus. So I think what people believe is expertise still, despite all the rhetoric that nobody does anymore. I think it's about are you doing your work seriously and thoughtfully and objectively? And are you giving that information that you have to the right people who do hold the trust in the community you're trying to reach or the population you're trying to reach? So I think that's actually less of a problem than kind of our current news cycle makes it appear to be. I think there's far less trust in public health than there is in actual journalists who do work every day.
Thank you. And Rachel and Adam and Jessica, do you have any thoughts on that? If you've done your research, you have your data, everything is set up, but you have someone who is not trusting of journalists to receive a message, how might you, or that's what they express, that's the nominal response that they give. How might you respond in that case?
So there are journalists who have grappled with these forces themselves. There's incentives to provide infotainment, not information. And I trust that. I listen to that. I think our most professional journalists are grappling with this. And how do we put a label on this is infotainment? This is not deep, trusted information. This is to sell you commercials. This is to sell you products. And to start to really facilitate those voices within the journalism committee, grappling with those ethics and amplify the results of that and the potential need, of course, respecting freedom of the press and freedom of speech. But people have a reason when they see infotainment to be hesitant. That's an intelligent decision.
Thank you. Rachel, did you have any thoughts?
I think Adam seems like he wanted to jump in.
Sorry, I didn't see that, Adam.
No.
I mean, I guess maybe three things. So, the people who are most trusted are doctors and nurses. I think that's how it polls generally, that most people trust doctors and nurses and those one-on-one conversations that we have with them. So rather than potentially arming, pundits or journalists or anyone else in particular with the information and the tools they need to sort of do these kinds of interventions, probably the most useful thing we can do is to arm doctors and nurses with the information they need. Of course, healthcare workers might be responsible for a proportion of misinformation and disinformation, but they make up a relatively small minority in the end, even if they might be particularly vocal. It also reminds me of the fact that appeals to authority and just putting doctor or professor in front of a statement doesn't necessarily make it more or less true, but it certainly is one that people use. And it's probably one of the signals that we should teach in critical appraisal, that appeals to authority are probably the things to watch out for because the information may be less useful. The other thing, I guess, is around how do we make sure we look after people in vulnerable communities? And when I say vulnerable communities, I don't mean minorities per se. What I mean is that people want to feel part of a community. And so the people who are most vocal about misinformation, the people who are rejecting advice that they would normally take on, are often doing that because they want to feel part of a community who's doing the same. And so I think identifying those smaller communities where people are trying to belong and infiltrating those communities is probably one of the other tools that we can use that would be most appropriate and useful.
Wonderful. Thank you so much.
Can I add to that real quick, Dr. Cohn? By the way, if it sounds like I'm disagreeing with anybody, just for those of you watching, I'm disagreeing in a very collegial way. We are all experts in our spaces. That's why we're here today. So this is how academics and scientists talk to each other. It's a lot of yes-anding. So how I will yes-and is remember, if you're based in the United States, that people do not encounter doctors and nurses. So we do not have socialized healthcare here. So even though our surveys also show that people trust doctors and nurses more than anybody else, they see a doctor, if they're lucky, once a year. That is not a strategy. So we need to, here in this country, we have to actually empower where people really get their information from. That doesn't mean you don't focus on HCPs. You have to, and they have to know what to say when they encounter their patients. But that is not public health. That is medicine, a one at a time approach. So in public health, we have to focus on what tools do we actually have at our disposal, which are community organizations, community leaders, partners that we have, and the systems in which those operate, because we have to work at scale. If I need everyone to know my inoculation theory message or my debunk message, I don't have the luxury of hoping that a physician someday will encounter someone who needs that information. I would also say, and this is fairly new research, so it's new to a lot of people, but yes, healthcare workers make up a very small percentage of the people who are spreading misinformation, health misinformation. But in terms of the health misinformation that reaches everyone, they make up a very large percentage. So it might be 1% of healthcare workers create disinformation and spread it on their platform, but that goes everywhere because they have the legitimacy of the institutions that gave them their legitimacy, and now they're weaponizing it against them. So it's a problem that we have to face, and it's not, I know that that's not true in every country, but here, if you have an MD after your name and you say, don't trust the CDC or don't trust mRNA vaccines, et cetera, that gets into every household that has an internet connection because of the letters after their name. So it's a fine point, but more work needs to be done there.
Yeah.
Thank you so much.
I'll add or expand. I think that there's a few things that have been said that are worth focusing on a little bit more. One is this challenge of consistency and voice for public health, because public health is really not an amorphous. It's not a one-size-fits-all field, right? We have thousands of public health departments across the country. They're all structured differently. It depends on governance of state, home rule, et cetera. And so I think that what fits in for one public health department, who's going to do it, what training and skills, et cetera, that they have doesn't necessarily fit somewhere else. So I think that there is just a challenge for the field in consistency of training, in consistency of voice, because public health really represents a very diverse field of practitioners, even when we call it public health. I think additionally, what public health does and the role that public health plays in a community varies significantly, whether they're doing any forms of direct service, whether they are administering programs, what programs those look like, et cetera. So the community touch points that Joe was just alluding to are going to vary in different locations. So I think trying to think about how we educate and serve the public health workforce to develop the skills needed to be more effective communicators is challenging, but something that we need to take on because it's going to look different in different communities. And I think that the key is partnership development and making sure that when there is the public health emergency, that is not when we are trying to do the communication and outreach to community. And oftentimes communication is kind of the window dressing on a series of policies and relationships that really needed to exist ahead of, long beforehand, but we think that communication can correct for it. And that's really not the case. And so I think that we are in a point in time, sort of an inflection period for the profession where we need to think about what does public health look like in different locations? How can we more effectively train and serve, given that kind of diverse environment, to build more effective consistency across the public health workforce when we need to communicate in an emergency or around an emerging issue. And that's hard to do, but I think it's critical.
And I'd like to close the loop. Those are excellent points on the fact that there are systems of accountability for nurses, for physicians. We have a contract with society and we are licensed by the state to carry that out. And so there are some pretty heinous instances of misinformation, and those systems of accountability worked, and we expect those. So all of us, I think, who are licensed professionals do understand that. But I also want to circle back on, there's often a misperception of clinicians as giving individual care one by one, but you have nurses who are running school health programs and they are reaching every child and every family in that school routinely. You have nurses in incarceration settings who are reaching those who do not have health care provided otherwise, and many population and community health nurses who are running extensive programs and have vast population and community health reach.
Thank you. Excellent. Quick question from the audience, and I'll remind the audience that you can drop your questions in the Q&A below the video player. From the audience, for those of us not in leadership positions, do you have any advice for wanting to be brave and to speak up? Any advice for dissenters or for correcting misinformation, but not necessarily, you may not have the support of your organizational leadership? Any thoughts? Joe, can you reference?
Man, I was hoping to dodge this one. I think if you work for a government organization, you're taking your career in your own hands, especially in this climate. If the person asking the question lives in the United States or works in the United States, other kinds of jobs and employment, there's a lot more freedom. What we're seeing with physicians and nurses is that increasingly they are all on social media. They're all getting on social media and they're trying to do, the good work. So they're trying to, these are people who are bringing solutions. These are not people who are problems. These are people who are, in a lot of ways, really, really standing up. I will just say it's nasty. So you have a two-pronged problem if you decide to do this right now. The first problem is, what is your employer going to say and do? That's more easily figured out because there's usually someone you can talk to and you can say, I want to do this. How does it work? Am I going to get fired? If you can get through those to the other end and you decide you're going to do it, and then you do it, what you're going to encounter is a tsunami of vitriol, a tsunami of nastiness directed at you. And that is a space I inhabit and many people who work in this space also. And it's really, it can be very scary and overwhelming, but there are ways to protect yourself. So, but speaking very practically, you would have to make sure that your cybersecurity is really set up for that, because you're walking into a fight. It's not fair, but that's the current climate. So anti-vaxxers and these quaint notions of people who spread misinformation or created disinformation in 2019 and earlier. That's not the space that we're in anymore. Largely what that information landscape is ancient. The new space is there are whole vast global networks of people and organizations who are highly incentivized to crush you the moment you get out there and start talking about vaccines or trying to educate people. That doesn't mean you shouldn't do it, but it does mean you can't just wander like a babe into the woods, naked, afraid, and alone, and assume everything's going to go okay. You have to make sure that your friends and family aren't connected to you publicly on your social media accounts. You have to make sure that the information you're giving is accurate and correct, that you're not using hashtags used by public health because those are tracked and they will find you. There's a lot of things that you need to do. There are resources that are out there. A lot of them are actually resources created for bullying and harassment that you can use to protect yourself and better equip yourself to have those public kind of conversations in social media. You can also, there's a program that we run called Shots Heard, shotsheard.org. It gives you some good tools. It's free. I'm not pitching anything. But I will say just, go in eyes wide open, because it's the whole reason why you think that you should do it is because there is a problem. And so educate yourself on the things other people who do it have to contend with every day, and then make a decision whether you think it's worth it or not. And I won't blame anybody for not wanting to wade into that space. It's oftentimes not a very fun one.
Thank you so much. Did any of the other panelists want to weigh in on that question?
I think if you really need a nice excuse, we have to remember that at the end of the day, an infodemic is about an overload of information, both good and bad. And sometimes it helps just to stay quiet. I use that as my excuse for not wading into that battle.
In that context, and in the context of Joe's comments, we could know from the previous presentations on history that it is especially important to understand the history of these groups, especially of racism, in order to do our work better. We were talking about applying these methods and then adapting them, the changing information environment. During the pandemic, we saw that some regions reached a sort of a threshold, and they weren't able to get past that. So some incentivization programs were offered of direct payments or even lotteries related to vaccine uptake. Does the panel have any thoughts on incentive-based as a last resort, or even as a first approach?
I think we have to remember that, the most important thing about vaccine uptake is access. That is much more important than attitudes and hesitancy, and that access to vaccines matters more than any of those things. So any of the tools that can support improved access are great. Any of the tools that can incentivize vaccine uptake are great. I don't think it's a one-size-fits-all problem, and everything that works.
Any additional thoughts on incentive programs? Rachel?
Sorry.
Oh, sorry. Sorry, Joe. I didn't mean to step on you. Joe?
I'll be really quick, Rachel. So I will say one thing we noticed was there's a difference between individual incentives to get your own vaccinated yourself and to get involved. And we did a pretty poor job in this country in giving people ways to have equity in their own pandemic response. And that was largely because we didn't know what was going on. So public health itself was spinning, trying to figure out what comes next. But in a flood, everybody in a neighborhood joins together and fills sandbags and redirects the water. And we have a way for people to help themselves. And that is a very American concept. We don't do a good job in public health of empowering people to chip in when we regard it as our domain. This is our job to respond to this pandemic. You all just stay home and be quiet and it'll be over soon. that was the prevailing idea that people got from us. So I think in the future, it'd be great to figure out what the equivalent of filling sandbags is, because I didn't see any lack of interest in getting involved and helping. I actually saw massive interest in every community we were in wanting to help and wanting to make sure people could get vaccinated. But all the rhetoric was about the people who didn't want to get vaccinated, and we kind of didn't give people a lot to do, and that's a big problem. And I'll end there.
Rachael, can we give you the last 30 seconds?
Sure, lucky me. I will just add that I think that at times we need to make sure that our incentives don't have backfire effects. So we can't tie necessarily individual behavior of getting the vaccine to societal reopening and then expect that we aren't going to upset a large portion of the population that is then going to mistrust or negatively view public health. So I think we really need to be careful about the way in which we are using incentives and how it's going to have implications for the future. So it may have an immediate effect, but it also may have a backfire effect that we have concerns about societal freedoms in the future, which are incredibly important to the American population. So I think that's the last 2 cents that I would add on this topic.
Well put. So thanks again. We're at time now. So thanks again to the panel so much for your remarks. And thanks to the public who put the questions in the chat. Now we can hand it over to Howard for our final session of the workshop. Thank you very much.